Place is not full here yet, but as they say, most of the important people are here, so we'll get started here. It's a pleasure to introduce Dr. Jens Chapman. He's going to talk about pelvic pain, I think, actually the sacrum, and all the problems that we can get with our sacrums. But I've known Jens for many, many years. He came to Harborview in 1990 after his training in Dallas to be a spine fellow with the Department of Orthopedics and Neurosurgery. We had a joint fellowship at that time with Dr. Grady Wynn and Paul Anderson. I think was Howard King had left. Paul Anderson was the main spine attending, and Jens rose through the ranks very quickly to become chief of spine surgery and then chief of orthopedic surgery. Has an illustrious career, has lectured all over the country, all over the world in various topics. I think Jens was starting at Harborview when the anterior and posterior cervical fixation techniques first took hold, and before that it was just wiring. So grew up with the introduction of all kinds of internal instrumentation for all the different parts of the spine. And the sacrum has been a lively topic recently with a lot of the controversy regarding management of degenerative diseases and deformities of the sacrum with new fusion techniques and so forth. And as you may know, with trauma situations, there are a lot of different fracture patterns that occur. So he's going to enlighten us, I'm sure, from stem to stern and tell us what's up with the sacrum. Thanks, Jens.
Thank you for the nice introduction. Numbers, and I hope to interest you in the next 45 minutes in the sacrum. And given the circumstances, I can't help but make a little statement, and that is, again, liberty is indestructible. And unlike the liberty concept, the sacrum is destructible, as you'll see. In terms of conflicts of interest, again, I don't think I have any pertaining to the topic at hand, but I'd like to point out that this talk was scheduled over a year ago before I was here, so this is how long the waiting time is to get on the grand rounds list. So I have no conflict of interest in terms of appointing myself, because at the time I was not running the educational committee. The learning points of this topic on sacral disorders are to hopefully expand your assessment capabilities, conceptualize a little bit about the stability of the sacrum, and then talk about treatment options. And in terms of the treatment options, I'm not going to talk about cement or pure percutaneous cement options. I'm not going to talk about SI joint pain per se. The pelvis as such is obviously, and one of the conceptual foundations of this talk is remaining the fact that this pelvis and the sacrum has really been kind of a terra incognita. It's been at the intersection, literally, of the spinal column and of the pelvis. And so in a weird way, I think nobody has really taken ownership of this. Not the trauma surgeons, not the orthopedic surgeons, and not the spine community, at least so far. And again, one of the weird things is that this bone is kind of the forgotten bone, and this is what interested in it for me right in the beginning. It's obviously a keystone, but it's somewhat mysterious. It is kind of a holy site, a holy theme. The name implies that, and it's truly the forgotten bone in the body. And you could ask, why bother? But frankly, without the sacrum, our spinal foundation would not be what it is, as this diagram represents. And again, the sacrum in its anatomic manifestation literally predetermines our entire posture. So this is, goes all the way up to the cranium. And so the stem to sternum analogy that Dave just used is actually quite apropos. If we forget about it, then something like this can happen. As a patient of mine at Harborview, where the sacrum basically had fractured. It was a simple insufficiency fracture, and it literally came through the skin and caused a major problem. So this was the patient's x-ray. And so we can't just forget about this bone, and it's a kind of miraculous structure for me, as I think and I hope you'll see. And again, if we forget about it, this is these are two case scenarios, one in the top sequence and one in the bottom sequence, where again patients were profoundly disabled. The patient on the top had a Charcot arthropathy, meaning a neuropathic dissolution of his bone, and this patient basically could not sit anymore. And the patient at the bottom from a tumor replacement. There was a recent patient here at the Neuroscience Institute, could neither sit, stand, or walk anymore, and again had been neglected for probably about half a year or so in terms of complaints. So the sacrum as a structural component, as a conduit for neural elements, has a profound impact on our general well-being. I will heavily concentrate on fractures, but not only, and again using fractures as a kind of a synonym for stability assessments and challenges that we face in assessment, use this as an example. And there are two main entities for sacral fractures. One is in high-speed situations where there's an obvious major kinetic energy dissipation in the body, and then increasingly low energy kind of situations where sometimes enhanced by surgical manipulations such as seen on the right-hand side, the sacrum simply fails and breaks down. And that's again a very much growing entity. Let me talk a little bit about the examination, which is frequently overlooked. And again, especially in the fracture environment, you might have an excuse for not examining the pelvis properly, because we frequently have to contend with hemodynamic stability issues, with pelvic ring stability being an issue, such as seen on the left-hand side, where pelvic clamp was applied to try to give some form of stability to an obviously disrupted pelvic ring. And one thing that is very commonly overlooked for all of those of you who take care of trauma patients is open fractures, which can be occult, for instance, in the vaginal or the rectal vault. And with a significant soft tissue contusion, which I'm going to show you in a second, there's also a very significant soft tissue component in terms of a closed environment that nonetheless has a major impact on patient well-being. A frequent problem, and one of those great examples of how we can simplify care very effectively, was the development or the discovery of the sheet. I know you don't take care of polytrauma here very much, but this was one of those miracle discoveries done at Harborview, actually, where one identified that one does not have to put these horrible big clamps on patients. One can actually simply sheet a patient with a roll between the legs, as you see here, and then compress their pelvis down if they have a disrupted pelvic ring, and aid greatly in the hemodynamic recovery of these patients. The problem with this is that this very simple tool, which is MRI compatible and everything if you remove the clamps, actually prevents proper examination of these patients. So while this was a great advancement and published and received enthusiastically, it actually also had a demerit in terms of making this the holy sheet and yet again contributing to the sacrum being the forgotten bone. And this is again the key point to the examination. One of the key points of the examination is that our patients usually present in a supine fashion and nobody examines them. And one thing that created almost anaphylactic reactions to me was seeing written in the note the words rectal exam WNL. And that's again just one of those things that means absolutely nothing to me. It's usually done by a medical student in an academic environment, which tells me that the patient was not properly examined. And again, a sacral exam does more or less include these four entities. And again, that's rarely properly documented. The basics, obviously, in a trauma situation, blood and a prostate location, but sensation, tone, differentiated and spontaneous and voluntary best effort, and reflexes. And again, those are not properly documented frequently, and they obviously bear a very direct inference to the health of the sacral roots, especially S2 through S4. And that's, again, something that if you're dealing with sacral more or less pathologic conditions, I suggest that that be part of the routine exam. Most of us are familiar with the plain radiograph environment, and again, that's something that, as we're talking a little bit closer, you might want to really delve into more and become familiar with, because all of us know of the AP images, but the so-called inlet and outlet views, seen here in the middle, we look into the pelvis by putting an X-ray beam straight down the pelvis inclination, or the outlet view, which basically looks at the en face view. Those are two images which give us a three-dimensional plasticity of this forgotten bone. A view that is frequently overlooked completely is the sacrum lateral, which is a very effective tool, but which most radiographers don't do anymore because it's just not really ordered. The CT scan is obviously the key test to get, and the one that we really pin everything down on. And again, a simple pelvis CT is something that, again, we need to have reformats of, such as seen here in the middle row, to kind of get a feeling for the three-dimensional alignment. And so having the pixels in that area to be able to be reconstituted in the sagittal and coronal plane is very important. And I would suggest that you have a low threshold if you suspect any sacral pathology. The 3D reformats, although the sacrum is, as I mentioned, a three-dimensional structure, is something that I've just not found particularly useful in everyday practice. It's certainly a nice tool and toy to play with, but it's not a profound thing. MRI scans, where do they stand? Obviously, it's a wonderful tool to try to depict neural elements, such as seen here. And I'll talk a little bit more about how to use MRIs in a second. But one very interesting tool that we don't use enough for is MRI neurography, which ex-UW colleague Jay Saruda had a great impact with, together with a neurosurgical colleague named Aaron Filler, who's now in LA. And this, again, is a technique where you can basically visualize the perineural fluid. And as seen here in this patient who had a significant L5 pathology, you can actually visualize injured or inflamed roots, such as depicted in this patient who then underwent an L5 decompression for an old ala fracture. CT myelography has a very limited role in that the sacrum basically usually does not harbor a dural or CSF carrying structure below S1. So it's sometimes that you get below S2, but it's a very limited value study for sacral pathology. In the big picture, we have to put it together, and we have to learn to take an X-ray like this and look at it in a three-dimensional fashion, looking through it more or less. And I could pick on any of the gentlemen, especially here in their turquoise scrub suits, to pick out what the pathology here is. Anybody want to take a guess what's wrong here? They're all putting their eyes down. I'm not going to put anybody on the spot. But this diastasis right here is a major problem. If you put an MRI then together with that, you can see that this patient had a sacral replacement from a chordoma. So this is a patient who had, again, this disease process going on for probably decades and had a metaplasia of the bone, more or less, a replacement of bone. You can see these very gradual kind of reformations of the cortical bone caused by this very slow-growing tumor disease, which obviously had to be resected. So learning to look through an X-ray is kind of an art, and again has fascinated me in terms of looking at pelvis X-rays. And this is again a sequence just from a recent patient who had a sacral insufficiency fracture. And again, if you look very carefully on the sacrum lateral, you can see that there's a crack here, and this crack then continued through and angulated down. And this is where an MRI is beautiful. If you look at the bottom view, it'll show you sacral insufficiency fractures very nicely. You can see this white streak going right through below the S1-2 segment. So an MRI as a screening tool for sacral insufficiency fractures is a very sensitive tool and a very helpful tool. In terms of alignments, one thing that's fascinated me in terms of the sacrum is the pleomorphism of this bone. If you look at the alignments of this sacrum on the right and the sacrum on the left, you can see these different, very different looking bones. And this from the same species. Why is this? We don't really know, but this is a manifestation of a collagen structure, of our collagen health. This patient on the right probably has a very soft collagen. It's probably more morphinoid kind of a person with gravity pushing the pelvis down. And the patient on the left probably has a very hard kind of bone structure. So the sacrum tells us something about the collagen infrastructure of the patient. We also now have a far better handle of the osteology of the sacrum. And one of the key findings that you'll see represented in some images later on is that this weight-bearing bone actually has very poor bone structure within it. The sacral ala, the wings on the side, are actually hollow. After about 45 to 50, especially in female postmenopausal patients, this bone really undergoes a fatty substitution and becomes literally hollow. So how can it be that this bone stays so strong, can support our weight? That's one of the mysteries I'm going to unfold, but the sacral ala on the sides are more or less a hollow structure with very thin cortical shells. So the answer is obviously that this is a combined structure, and the ligaments here, and these coarse subjects, I'm sure Dr. Tubbs will help us get much more differentiation there. There are mainly 4 families of ligaments that support us. The posterior sacroiliac ligaments, see very coarsely represented here, are again probably the main reason why this very thin bone structure on the side can even survive. And again, this is a ligamentous complex. There's an interosseous complex that are not represented here within the sacrum. They're the anterior SI ligaments, which are very thin. And then there's a favorite ligament for anybody who does lumbosacral fusions, the iliolumbar ligament, which combines the L5 transverse process to the pelvic ring. So whenever you see a patient who has a broken L5 process, transverse process, that's a big deal. Why? Because that means this patient had a ligament disruption of this very big, broad ligament, the iliolumbar ligament. So this is not a trivial finding. So this is just a depiction of that iliolumbar ligament. And yes, Shane, this is something we'd like to really differentiate way more. A word about sacral neuroanatomy. Again, this is one of those overlooked phenomena. I'm so glad to see so many of our physiatry colleagues here, because this is truly something we can possibly work on together way better. There's a spatial mismatch, more or less, of the ratio of the filling of our foramina to the nerve roots. So S1 does not have a lot of extra room. The S1 foramen, the ventral S1 foramen, is mainly filled by nerve roots. So if there's a pathologic process, it does not take a lot to actually irritate and make this root dysfunctional, as opposed to the lower roots, in which, again, there's a large extra space. So S2 through S4, the control nerves for our bowel and bladder and sexual function, actually have a very plentiful space to get out. Now, electrodiagnostics. I'm out of my league here, and I have experts here in this room, but this is a really big deal. Why? Because with EMG, we actually have a pretty limited ability to actually look at sacral lesions. It's mainly restricted to the L5 and S1 roots. The anal sphincter EMG is something that we used quite a bit at Harvard. It's obviously not a very comfortable one. And again, EMGs usually have a significant delay in manifestation. Kim, is that right? About 3 weeks, 4 weeks? Will? Something like that. Pudendal SEPs are something that is very helpful. It allows for S1 through S4 monitoring. But again, it's used, if you ask for it, intraoperatively quite a bit. We don't have good sensitivity or specificity. This is one of those more or less tests that would be possibly expandable in the future. One thing that we don't have, to my knowledge here, is good uroneurology kind of services, a crossover more or less of electrophysiology and neurology with urology. And again, bladder CMGs and post-void residuals are very important for neurogenic bladders. Neurogenic bladders are ubiquitous in our practices with seriously ill patients. And this is, again, one of those tests that we probably really could, especially here in Swedish, work on to get a crossover more or less of specialties. So maybe part of this lecture can serve as a stimulus towards developing a neurourology kind of expertise. Now let me digress into fractures a little bit. And again, this is just a scheme that shows how these fractures can occur. When we look at fractures as a kind of an example for stability and instability, one of the first things that a Swiss gentleman named Balz Easler was identifying was this crossover phenomenon of sacral injuries to the pelvic ring. And he made a very important discovery, and that is that the fractures are lateral to the L5S1 joints. These are more pelvic ring fractures. If they're crossing through the joint, or certainly are medial to the joint, this becomes a spinal pathology and is something that's associated with neurology and requires more or less a spine strategic approach. So that was one of those key first things to try to understand where the pathology is and what kind of fixation strategies we want to use. One of the classic kind of systems of skeletal differentiation was that of Francis Denise from Minneapolis, one of the teachers, I think, of Dave Hanscom, right? He was there when you were there. And that is the 3-zone system. This is something that is helpful for fractures, for tumors, for anything in the sacrum. I suggest that we still use this because it's so very helpful. Zone 1 injuries are lateral to the neuroforamina. Zone 2 injuries go through the neuroforamina, and anything that goes into the spinal canal is a zone 3 kind of a lesion. And why is this important? Classifications only make sense if they correlate to patient outcomes. And there's indeed a very close correlation. Zone 1 lesions have something to do with the L5 root. Why? Because the L5 root courses right over this lateral shoulder of the ala and is actually tethered by a small ligament in the front of the ala. Zone 2 lesions go through the neuroforamina, and up to a third of patients have some form of pathology, mainly in terms of the upper roots. Not surprisingly, the S1 root, again with its very limited space, is a primary target for that. And zone 3 lesions have a 50% involvement in a Cauda Equina syndrome. So that's a really big deal to kind of understand how medial the structural lesion, whether it's a fracture, a tumor, an infection goes. A wonderful subclassification was done by Roger Roy-Camille, who is, by the way, for those who do spine surgery, the godfather of posterior segmental fixation. So the posterior cervical fixation and pedicle screws go back to this wonderful Frenchman. And basically, the displacement in terms of angulation then translation, and then actual dislocation or segmental comminution was his contribution towards this. So we basically have to have two classification systems in parallel, the Denise and then the subclassification of Roy-Camille for the zone 3 lesions, to kind of get a severity expression of what a sacral fracture looks like. What we frequently do in the middle of the night is we use descriptive terms, and again, you need to have a CT scan to make this happen. You can basically kind of visualize an H, a U pattern, a T pattern in there. One thing that is very clear, and that I, again, want to point out to all the trainees, is there's no such thing as a pure transverse sacral fracture. It's almost impossible. You can have it in the lower sacrum, but not in the upper sacrum. A very important neurosurgical contribution was actually to try to listen to patients. And so a neurologic impairment of Cauda equina is not something that was in the literature until sacral fractures were looked at a little bit more. And Gibbons basically contributed this four-part, where basically there's either a healthy patient or a patient with bowel and bladder dysfunction present. One thing that has become very clear, and that also pervades into our Asia classifications, is that patients' satisfaction is highly dependent upon bowel and bladder continence and sexual function. And sexual function is something that, because we're prude Americans, I guess, was never asked in either the Gibbons classification or in the Asia classification. It's a sore, kind of a overlooked entity, and should probably be looked at more in detail in the future. In terms of decision-making of what we do, we again have a host of things to look at. We want to look at the stability, and again, look at whether there is a lesion that's more bony or has a ligamentous involvement. And they can be occult versus obvious. The neurologic status is very important in terms of, is it an intact patient, an incomplete patient, or is it a hopeless situation where there's been a clear disruption of the Cauda equina? And looking at the soft tissues is a very important point, because contusion, such as in these blue discolorations here, these ecchymoses, or actual deglovement, where the lumbodorsal fascia dehisces from the skeletal underpinnings, is a really big deal. And obviously the occult open injuries I talked about earlier. Let me talk a little bit about non-operative care. And again, there's actually something to be said for that, but it's a very important differentiation to make. Non-operative care works. There are some indications. If you have, for instance, a fracture, it's a single system problem, there's no soft tissue compromise, and this can range from protected weight bearing to bracing to recumbent traction. And the outcomes are unclear, but in general, there's an about 80% role for improvement. I'll show you a case from very early, and so this takes us back to when Dr. Newell was my attending at Harborview. This is in 1991, and I remember I was on call. I was a brand new attending, and all my attendings, Dr. Newell, Dr. Grady, Dr. Anderson, were out of town, and I had this huge young guy who was neurologically intact with this, and I couldn't make a test out of this here with Dustin, but I'll spare you that. It's a zone 3 injury, and it's a Roy-Camille 3, so it's a pretty bad injury. Miraculously, this patient was neurologically intact, including a very detailed rectal exam. But this is clearly a sacral lambda type fracture, a zone 3 injury, a pretty bad injury. I was pretty overwhelmed with this. This also turned out to be a gentleman who, for religious reasons, would not allow for any blood transfusions. So I decided to put him into bilateral pantaloon spicus. I put him into a nursing home. I kept him at bed rest for 3 months, and this is his healing result. Now, I don't know how many low back pain claims came out of this lug of a 300 or 280-pound man being in bilateral pantaloon spicus for 3 months in a nursing home. But he healed, and he healed beautifully, and his blood loss was 0. There's obviously a risk of blood clots and pneumonia and other factors, but sacral fractures can heal. This is very important in terms of sacral insufficiency fractures, because if we detect them early, we can actually heal these without having to squirt cement into them or do anything else. One finding that we had in a larger survey of sacral fractures that we did was, especially if we have fractures, there's a very high incidence of distracting, very important other injuries. Head injuries, for instance, 21%. So 1 in 5 patients had major distracting injuries. The sacral ring was disrupted anteriorly, usually in half of the patients. So these are patients who, when they have fractures, require a multi-organ system assessment. In terms of surgical intervention and decompression alone, without any hardware now, the indications are quite clear. If we have identifiable neurologic deficits that are of threatening, meaning major fashion, there's a mechanical impingement of the neural tissue, that's something where I think we can really think about how to do it. And the methods are actually very straightforward. It's something where a lot of surgeons are not trained into it, but it's actually a very straightforward entity with surgical expertise such as you have that's very doable. You just have to work on cadavers and learn how to use imaging techniques. But basically a focal femonotomy, a laminectomy, a ventral disimpaction, understanding where the sacral plexus lies and how to dissect it out is all you have to do. Yet again, the outcomes in the literature in general are unclear. 80% of results are reported as good or excellent. And the question has been whether it's better than non-operative care. So just some tips and tricks of how to do this. Basically, you want to learn how to identify the shoulder of the roots and separate them from their venous plexus, and then eventually go in. You don't have to do a major decompression. You can usually do this through a very focal small incision, such as done here. And if the spinal canal is impinged, you can actually slide these impactors under the roots and then eventually disimpact it so that you can get the gibbous, for instance, away from the Cauda equina. Again, these are not very major surgeries. It's about 1 inch or 2 inch incisions. That's all that it takes. The rates of neurologic improvement, and you can see these case numbers are very modest, are actually pretty consistent, and operative patients have usually been better than non-operatively treated patients. When do we stabilize the sacrum? Again, the indications are an unstable pelvic ring, a compromised soft tissues, are patients who need an extensive neurologic decompression. And again, if there are historically speaking, disrupted pelvic rings, we can basically use a plethora of different opportunities. The reports in terms of outcomes are all over the map. Infection rates can be daunting, especially in posterior open procedures. And again, results can be seen as positive in terms of fracture union of up to 90%. They can be seen as questionable in terms of persistent pain, about 30% of patients. And again, mechanical constructs have been really something that's been the bane of our existence, because replicating with surgical tools, this miracle of our lumbopelvic junction, have been very, very improvisational, such as this construct on the right-hand side, and really problematic. The demands on the lumbopelvic fixation are profound. They have to be stable. They have to be very low profile, because if you touch your backside, there's not much separating yourself from the environment. It's basically the only muscle that separates your posterior sacrum from the environment is, Brandon? Caught you sleeping. The multifidus. You guessed it. You were going to say it. I saw you verbalizing it. It was on your lips. And so this is this inverted T-shaped kind of a construct. And again, these are these things that surgeons used to kind of put into patients. And again, from an aesthetic standpoint, they were really problematic, biomechanically insufficient, and you just held your breath and hoped that everything would stay. And again, this is just another example of the improvisational structure. And this is something that we grew up with in the early 90s. There was just not anything to really fix patients' pelvises properly with. There were multiple techniques used, and again, sacral bars and plates were put through, and I just always was horrified by the disruptive nature of these surgeries. Again, Roger Roy-Camille developed posterior plating of the sacral ala. We put a plate laterally on it, and this was actually a patient we did in Harborview in the early 90s, who was a suicidal jumper with a zone 3 injury and a Roy-Camille 2 injury and neurologic decline. We did a sacral decompression, did these as eye screws, and put these plates on there. There's a profound problem with this. There's no fixation for these screws. These little screws have to be very artfully placed to gain some purchase, because the sacral ala is literally a vacuum, as I said earlier. There are Germans who put in plates into the neural canal, which I still don't understand how you can do that. So with all sympathy towards Germany, that's something that I just don't understand. But the big breakthrough was, and this is something where Harborview made a little bit of history, was these percutaneous sacroiliac screws. And this is something that is being very heavily touted by industry and a couple of physician proponents to be done for the treatment of sacroiliac pain. And that's a whole different can of worms that I'm not going to go into here. But from a trauma perspective, this was very appealing, because fractures such as seen on the top here could be all of a sudden closed, reduced, and then percutaneously treated with these screws that had to be artfully placed across the pelvic ring. And again, that seemed to be a breakthrough. The indications were, again, very specific fractures, such as the one seen on the top left, and we'd basically put these screws through and get a very nice realignment. This is actually a case that we did where this patient had an impingement of the sacral foramen, and after the percutaneous reduction, there was a persistent large bone fragment in there with a very small incision. We actually then posteriorly fished out this bone fragment, and this patient went on to have an immediate resolution of the sacral radiculopathy. So identifying this and interacting early with a decompression is a very efficient way to go. Now, in terms of fixation, again, there's a profound and very large biomechanical force placed upon the lumbosacral junction. And how to replicate that surgically has always been a challenge, as I said earlier, and this is a great diagram to look at this, because if you don't have good fixation, this will happen. And again, the solution is obviously to try to have much bigger outriggers that give you a solid foundation as you're trying to reestablish surgical connections to the pelvis. And this is something where our former fellow, Thomas Schildhauer, who was with us in 1996, seen on the top right-hand side as a minor in his hospital in Bochum, made a big history because he, for the first time, really identified in his German fashion how to put pelvic screws in properly so that they'd have maximum fixation. And so, in a way, he can be considered the godfather of proper iliac fixation. And this is the landmark article. And things like this, where these percutaneous screws would just fall apart and break, would be a thing of the past. So this is a case and example where at Harborview we had a patient with a complex zone 3 injury, treated with these screws, very nicely, very artfully placed, and the patient was mobilized, and just sitting up, not even walking, the whole pelvis moved backwards and shifted out of place. So this is just overwhelmed, and this was immediately stopped by putting lumbopelvic fixation in and realigning the pelvis, and the patient could actually weight bear without a brace immediately. You can see the staples in there. This patient could walk right out of there. So this is obviously a more invasive procedure, but it's biomechanically very sound. One of the big questions was, should we fuse these patients, meaning should we try to create a bony bridge in there beyond the hardware? And again, this is something where the Germans and we have gone separate ways, because the Germans take the hardware out after about a year. We usually try to fuse the patients. But this is one of the articles where we basically could show the value of pelvic fixation and of this properly done lumbopelvic fixation, which has now become a standard for a lot of our scoliosis surgery, for instance. And if you, as fellows, want to see how to do this, we had Dr. Schildhauer here last year for the trauma course, and he's promised to come back next year and just go on the wonderful SSF YouTube channel, and you can see the master himself showing you how to put in the highest precision pelvic screws imaginable. And he'll come back, I think, next year. Rod, the conference next year is in May again, the trauma course? Yeah. So he's promised to come back, and maybe you can get hands-on lectures by him. It's a wonderful, very methodical, very clear way of how to put iliac screws in. Biomechanically speaking, there's a huge difference, and it's way better if you put these pelvic screws in for an unstable pelvis than the percutaneous SI screws were. And you don't have to disrupt the soft tissues too much. We basically make a midline incision and then work our way laterally. There's a little bit of an art in terms of preserving the posterior roots, which form the, Brandon, should I pick on you again? No, you're awake this time. The cluneal nerves, yes, sir. So the posterior sacral S2 through 4 roots contribute to the cluneal nerves, which give us the posterior integument sensation. And so how to trajectorize these is something that we've looked at and learned to be much better about. And again, there are differences in the male and the female pelvis that we have to account for. But basically, we can put very substantial screws up to about 140 millimeters into the pelvis. And what it takes is in the imaging suite to develop an appreciation for the sciatic notch, seen here under the yellow arch. They have to be perfectly superimposed, and you want to be aware of where the acetabulum is. And then you can basically place these screws above the sciatic notch. And the radiographic views that all of you have learned and that I see done here are these specialized oblique views, seeing these wonderfully detailed, I'm not very good in computer art so far, as you can see, oblique trajectories, and our imaging techs are actually getting better and better at trying to make these views happen. But these are these various views with which we can see the obturator and the iliac obliques to make sure that these screws are perfectly placed. And again, sometimes we need to use sacroiliac screws. You'll see a case example later, done recently here, where we had to place SI screws, but that's something where we can achieve an additional reduction effect with. In terms of how often do we do these more extreme fixations, at Harvard we did a retrospective analysis, and in the vast majority of sacral fractures, we were able to treat these patients non-operatively. So there's no complete change in treatment, and the vast other majority of patients were treated with sacroiliac screws. So these more invasive, comprehensive stabilization procedures were fortunately only necessary in a minority of patients. That's just the minority. But we did look at those patients. We wanted to see how we actually did with those. And we did a number of studies on those to try to understand what we actually did. And you can see a case example on the left-hand side here, and then a post-reduction film on the other side. And we basically found that we had no non-unions. We found that we could restore a pretty normal sacral anatomy. We could literally reposition the sacrum however we chose it to be to repair the patient's original anatomy as good as possible. So radiographically, we could achieve a great improvement. We did go through a very comprehensive assessment of these patients that at the time was unprecedented in terms of how do these patients do neurologically. We found that with surgery, we could achieve an 83% improvement, and the patients who did not improve were those who had a complete disruption of nerves. We also found that if you have unilateral preservation of S2 through S4 nerves, these patients actually were able to be continent in bowel and bladder, which is a very important insight and replicated by tumor surgeons. What we don't have a good understanding for are the parasympathetics, which are basically ventral to the sacrum, which mediate sensation for the bladder and the bowel, which we've seen in tumor resections to be very important, because if we take these, and we have to sometimes, these patients can have impaired bladder function especially, despite having intact S2 and S3 ventral roots. In terms of complications, we did a reassessment of those, and again we found that a rod breakage in our patients was a big deal. Interestingly, this is not correlated to patient-reported outcomes. These patients frequently did not know that they had a broken rod, and they were actually pretty happy, so there's zero correlation. We found that hardware prominence was still somewhat of an issue, and infections were present in 17% of patients. And that's a big deal because these are, again, posterior midline incisions. They're in a very precarious area, and they're close proximity to enteric colonized orifices of our body. So this is a high-risk area. So becoming very meticulous about soft tissue management, trying to prone patients, trying to use vac dressings, doing multi-layered plastic surgery closures, being very attentive to CSF leakage is a really big deal. And this is, again, a reality that, especially in trauma situations, we frequently had to do with. When the pelvic ring disrupts traumatically, you can frequently have these horrendous deglovement injuries. And again, these are closed open injuries, which are pretty profound. And we've basically gone on to just INDing those patients several times intentionally to just keep this soft tissue seroma from forming a nidus for infections. So hardware complications we studied specifically because we had rod fractures with the systems that we used at the time. We again found surprisingly that patient-reported outcomes did not relate to those. A very important factor, however, was that we had to be low profile with the hardware. And this is a problem for a lot of implant manufacturers out there who create these huge monstrosities that then bother patients quite a bit. So they're bothered not so much by hardware breakage, but by prominent hardware. So becoming very artful and trying to hide these screws under the pelvic crest is a really big deal. And again, there are some tricks in terms of carving out a niche in the sacrum to try to really make them as low profile as possible. It's not always possible. We basically underwent a couple of changes, and we then did a follow-up study in the mid-2000s to try to see, can you close the shades, please, Jason? Thank you. Sunshine in Seattle, it's a blessing that's a problem. And what we found was very interestingly that, again, we basically saw that there's a change in trends. We did more unilateral follow-ups, and we found that, again, the correction had kind of suffered. So the ability to not change the angles too much had changed, and we felt that this was an interesting phenomenon because a newer generation of surgeons had started to do these surgeries, and they're probably faster, but they also didn't place the fastidious importance on reduction that the older generation had done. So we don't know what that means, but it was just an interesting change in terms of seeing a generational change. And this is a case example with a patient with a L5 weakness bilaterally, and again, a complex sacral injury. And you can see that this is a zone 3 injury with a very low transverse component. And this was, again, treated initially with sacroiliac screws. It seemed to be a great idea, except for the fact that on post-op day 4, just sitting up, the screws sagged and the patient changed. And if you just look at the change in angle, you can suddenly see how this patient turned into a sacral inlet view. You can see how the sacral inclination, just on a CT scan, a recumbent CT scan, suddenly changed completely in terms of its angulation. And the patient had increasing pain, which is always a very important hallmark of stability assessment. And we basically decided or felt that these sacral screws were not doing the job. We did an intraoperative reduction of this sacrum with a variety of tools, which then becomes pretty painful. But we put in lumbopelvic hardware. And again, this construct allowed the patient to, I kid you not, walk literally out of the hospital several days later in full weight bearing. So this is, again, just a change in terms of how the sacral inclination is important and how you can more or less make or affect change by picking it up early and helping patients. The clinical hallmark is literally listening to the patient, and for me this is one of the most important things to pick up. When patients hurt when they're up and they're comfortable when they're down, that tells me that their spine and their sacrum, if it's in the lower back, is insufficient in terms of carrying their load, and you have to then attribute that to it. So in terms of sacral fractures, again, this is a very a potpourri of a couple of injuries, but it's amazing to me how the sacrum can be hurt. And again, we do now have a very potent way of restoring the lumbopelvic junction with surgical techniques. Now let me talk about sacral insufficiency fractures briefly. This is something that has grown in numbers dramatically, and we have absolutely no incidence numbers, but it's something that I think all of us who are practicing medicine are seeing increasingly. And this can be young, high-performance girls, it's mainly female patients, or it can be elderly patients with significant osteopenia. They all share a hallmark, and that these injuries are usually crassly overlooked. And Glenn, you probably agree, the ones that you see, they've been managed for months with back pain, and nobody has really looked at the sacrum. So I'm not saying that we should be crazy about it, but this is, again, something when you see on a pelvis AP x-ray, this round hole, the inlet view, that means that the sacrum itself has sagged downwards, and the patient is getting this pseudo-inlet view simply due to the sacrum tilting under the influences of gravity. And this is a very common phenomenon. If you take the rod actually low enough, you see how the sacrum is fractured through and through and displaced. And if you don't treat this, these patients will basically always tilt forwards and then become increasingly painful as time goes on. A hallmark, again, is if you get a CT scan, how devastated the sacrum is. And again, this is truly something that we, in all specialties, have to become way better about, and that is looking at bone health, for instance, on CT scans. And thanks to Chris Schuhart, we're actually going to be able to quantify on CT scans in the not-too-distant future patients with poor bone stock. Now, I think all of you will agree that if you look at this image here, you don't need to have a quantification CT scan to see that this patient is in desperate need of metabolic help. And this is, again, not a surprise that the sacrum would undergo this catastrophic fracture. And this is actually a patient we treated surgically here at Swedish not too long ago, because this patient had this completely neglected sacral fracture, and he actually did very well with that. He was able to weight bear. This is, again, something that we have created as surgeons now, with increasing numbers of spine fusions being done. These patients can break apart in their spine below, and this is, again, what happens right here. We have to be very aware of this. The usual situation is that these patients have been treated with surgery, everything went well, they're actually happy, and then they come back at 3 weeks post-operatively. And Rod, right, we're all rolling our eyes and going like, typical. Not typical. They usually have something going on, especially if they start walking forward tilted. We have to look at their pelvis to see whether the foundations of the fusion still are intact. And this patient really fell apart right below her fusion. This is actually a very grateful patient. We treated her. I could not get, she came to me like a year or two later. We had to do a very complex reconstruction on her. She was actually extremely happy just with this, I would call it insufficient restoration of lordosis. So the main thing about sacral insufficiency fractures is to identify them, be very cognizant of them. Don't let them come to the point where these patients lose bowel and bladder control, such as seen here at this S2-3 fracture, because then again, surgery still may help, but it's not quite clear what we have to do. And again, early intervention is clearly the way to go. The other factor is, again, listening to patients more, and this is probably the main gist of the message in terms of stability. Listening to patients in terms of what they can do. If they can't sit anymore, if they can't stand without pain, they have a problem. This is a patient with a metastatic hypernephroma who could not even lay on her back anymore. Her pelvis was this painful. It was so insufficient. And again, we need our sacrum to sit, to stand, and to roll around. She had to lay on her right side to be comfortable. We had to do a very complex surgical reconstruction aided by our very capable interventional service to block the vessels. And this highly vascular lesion, we were able to repair her pelvis quite nicely with hardware from the back. Another factor are paralyzed patients. I showed this image before. This is a patient who's basically dissolved his lumbosacral junction. and this is a very grateful patient of mine. We were able to replace his pelvis with this transverse bar and fix his pelvis. He had a Charcot arthropathy. His presentation after about 6 or 7 plastic surgeries was a CSF leakage through his wound that the plastic surgeon couldn't control with flaps anymore. The reason was he did not really have a CSF leakage as his primary problem. He had a Charcot arthropathy, which was not recognized in this highly active patient who dissolved his lumbosacral junction. This is a summary slide of the state of the sacral fracture literature, and I'm showing you this unreadable slide for one and one single purpose. That is, there's basically only level 3 and level 4 incidents, and these are all case series, including our own. So the status of the literature is highly insufficient. It does not have very sophisticated neurologic assessments in terms of neurophysiologic testing, so there's a huge room for improvement. If we're dealing with fractures, basically the literature had always talked about intervening within a couple of days. From a neurologic perspective, the best evidence says to intervene within 24 to 72 hours. So patients who have had, for instance, bowel and bladder loss over 2 weeks have a much diminished chance for recovery. In terms of outcomes testing, the Swedish surgeons have really done the best job of that, I think. They've identified that patients are mainly troubled by urologic dysfunction and sexual dysfunction in a third of patients. And again, the pain correlation to anatomic reduction is somewhat vague, but basically trying to stay within a centimeter of alignment is something that's kind of the norm. It's become the norm, and it's not necessarily scientifically that well founded. In terms of outcomes from the fracture population, 67% of patients returned to work, and the physical impairment was actually relatively well situated with more modern internal fixation techniques. So the questions in conclusion are, when do we do these more invasive pelvic fixation techniques? What are the long-term results? The role of cement injection is something I've not really addressed because I personally don't have any expertise with it. It probably has a role, and we can gladly have Glenn maybe comment on that also. We still don't know whether to remove hardware or try to fuse these patients comprehensively. Wound management is clearly the one main issue that we have to do surgically. I hope in conclusion that I've shown you that the sacrum is an integral and magical keystone part of our skeleton that deserves far more attention than we've given it to in the past, and that hopefully this brief survey has kind of shown you a little bit of what's going on in there. And we can remove the sacrum from the status of the unknown or os innominatum category. So there's a plethora of pathologies that affect the lumbopelvic stability, maintaining an anatomic alignment, intervening early, recognizing these injuries, and then intervening surgically also sometimes with percutaneous techniques or lumbopelvic techniques as shown can make a big difference. With this, I thank you. It's been a great year here, and I hope we have many more great years. I feel so lucky to get to be here. Thank you for listening. So, questions? Glenn, when do you do sacroplasties or cement into the sacrum?
Situations where they have not healed for months on end and severe amount of pain. These patients can do very well from sacroplasty itself. But a lot of the
What do you inject? Do you inject the S1 body or what?
just below the sacral iliac.